So before we start, the primary panelists for this quarter are Dr. Ramakant and myself, and other panelists are Dr. Tanvir and Dr. Ava. So for myself and Dr. Ramakant will be spending 10 minutes. Dr. Tanvir and Ava will ask for 5 minutes. And other teams, then the question will be shifted to other teams can question, moderators and judges can question later on once the process happens. So with this, Dr. Ramakant,
Yeah.
if you're available, please start with your questioning to team.
Greetings to all the seniors and my dear friends, and all the best to all the team. I will start my first question for the team one. What are the characteristics of full thickness burns?
So the full thickness burn, there will be involvement of deep dermis or muscles, or there will be involvement till the bone, and it will look leathery, white and dry. There will be no pain.
Yeah.
No blistering will be there, sir.
Yeah. I think the answer is correct.
Yes, sir.
Should I go for second question?
Yes, sir. Please continue.
Yeah. What is the major concern with deep burns on such female patient, especially on the breast area? Shall I repeat?
So the complications.
What is the major concern with such deep burns on female breast area?
Yes, sir. So the breastfeeding after she conceives will be the major problem. She will be going into contracture if early intervention, especially surgical intervention, is not done.
Yeah, I think
And the compartment, trunk compartment of the chest, compartment syndrome for the trunk.
Your first answer, I think, is near to what I expected. That is, the viability of nipple and areola is the major concern and deformity of breast in these patients, and which can, as you said, can lead to difficulty in breastfeeding and all. So I think this answer is also correct. Third question, what are the indications of tangential excision in such burns?
Sir, difficulty, no chest rise, especially difficulty in breathing, or there is no
indications. I am asking about indications of tangential excision.
Sir, full thickness deep burns with involvement of dermis.
Yeah, perfect. Perfect. Deep second degree burns and third degree burns are the indications for tangential excision. My fourth question is, what should be the chronology or priority of wound cover in this patient particularly, where there is involvement of face, chest, abdomen and groin, both groin? How should be the chronology of wound cover?
Sir, the chronology can be varying, but we should protect her eyes, her facial burns first, followed by neck on joints, especially the major joints, followed by the trunk, sir.
I think the question will pass to the next team. I expect another answer.
So we'll do the tangential excision in the areas of areas involving deep dermal burns only.
Which areas? Which areas? Priority-wise, which areas? You just see the areas of burns, and what do you think?
First, we can go for chest and bilateral upper limbs, followed by abdomen later on. And we'll see if the face doesn't heal by 2 weeks, then only we'll proceed for tangential excision over face.
I think I expected other answer from both the teams. I don't know what is the rule, Dr. Mohapatra. You can guide me. What should be done? Should I answer?
maybe we can answer once this discussion is over, this slide discussion is over. Then maybe you can answer the questions which they did not tell well.
Yeah. I think in this patient, if you see carefully, both the shoulder clavicular areas are involved and both the groins are involved. The chronology of wound cover should be, first priority should be the access for CVP lines. So both the necks and groin should be excised and covered first, so that before infection sets in, these areas will be available for IV access. That is what I expected. My fifth question is,
No team
What
gets
is-
the marks in
Yeah.
this.
Please
what is the
continue.
best option to prevent bloodstream infection due to CVP catheter in such burns patients, where you have seen the wounds at all the 4 areas of CVP? How to prevent bloodstream infection?
Sir, peripheral lines are to be preferred where unburnt area is involved, and proper catheter care followed by sending the tip for the culture as early if there is signs of infection or sepsis is there.
Maybe my question was not clear, but I will clarify further. Is there any special catheters available for prevention of bloodstream infections? Because these all are potentially infected areas, burnt areas. Team 2, I think team 2.
So we can go for peripherally inserted central line from the uninvolved region in right upper limb. As I can see, it is not burnt. So we can insert a peripherally insertion of central catheter.
Almost all the areas are burnt. The proper answer which I expected is there are especially antimicrobial coated catheters available, which are either coated with rifampicin and miconazole or minocycline. And these protect the CVP for 30 days with slow release of this antibiotic. These are special catheters available. I finished my 5 questions. I think Dr. Devi can go
Yes,
for
sir.
next 5 questions.
Thank you, sir.
Yeah.
So my question regarding this spotter will be to the team 2. So team 2, the first question from my end is, you see this patient, female patient with acute burn, which according to you is the most critical area of this patient burn in with regards to burn management? Which according to you is the most critical area with regards to burn management, initial management of burn?
So bilateral breast region, neck, neck
Sorry?
and neck and bilateral breast region.
No, one of you can tell, please. I cannot hear.
So, neck and bilateral breast region are to be addressed. Neck region needs to be addressed first because
You have to tell the most critical means only single answer is correct. You have told multiple points. You are given a chance. Any single area which you think is the most critical.
Priority.
Shall we go to team 1? Can you tell which is the most critical area in this patient as far as initial management of burns are concerned?
Face, sir.
Sorry?
Face.
Face. Correct. The airway, no? First we start with the airway. In anything we go with airway first, then the other thing. So the next question to team 2 again. What are the signs or features of inhalational injuries which you should look for in such patients?
sir, if there are deep facial burns or if there is hoarseness or stridor in speech, then we are going to suspect inhalational injury. And a history like burn in closed space, if there is a history of loss of consciousness, then we are going to suspect inhalational burns. And we want to look for signs for singeing of nasal hair and carbonaceous sputum. So in those cases, we are going to suspect inhalational burns.
We accept the answer. Okay. So this patient of acute burns comes to you. So what is the standard fluid regimen, fluid protocol?
At our center, we use Parkland formula, in which we resuscitate the patient with 4 ml per kg of total burnt surface area. And it is divided into half of it is infused during the first 8 hours, and the next half is infused in the next 16 hours.
Okay. When you take this formula into consideration, which burns will not take into consideration?
So, for electrical burns, we
No,
need
in the same patient, which burns will not take into consideration while calculating the total burn PBSA?
Sir, we don't want to include the superficial burn, sir.
Superficial, what degree? How
First
do
degree
you-
burns. First degree burns.
First degree burns will not include. Then how do you monitor the adequacy of your resuscitation? Your fluid
So,
administration adequate?
So we want to catheterize the patient and look for early urine output. The urine output, it should be titrated such that for an adult, it should be between 0.5 to 1 ml per kg per hour.
Okay, correct. We accept your answer. Now the final question from my end will be, is there a role of early enteral feeding in this patient? Are there any benefits? Sorry. Is there a role of early enteral feeding? Are there any benefits in early enteral feeding? Enteral feeding.
No, sir, we don't go for enteral feeding. We go for oral feeding only, sir.
That is, there are two feedings, parenteral and enteral.
Early.
Enteral and oral. So when is there a role of early? When do you start the feeding?
After 24 hours, sir, as initially there are chances of development of paralytic illness also. So initially we manage by IV fluids, followed by liquid diet, then oral diet.
What is the benefit of giving oral feeds? What are the benefits of giving oral feeds? Can I ask team 2 to team 1 to answer this?
Yes, sir.
How does enteral feeding help in this kind of burn patient?
Sir, is it passed to us, na?
Sorry?
Should we answer, sir?
Yeah, you have to answer this. It's a
Yes,
past
sir.
question.
Early enteral feeding has got advantage of decreased hospital stay in long term, decreased mortality of the patient. There is increased GI immunity, and especially IgA is increased over the mucosal layer of the gut, and IgG in the blood is also increased, and flora of the intestine is also maintained. So basically, early enteral feed has good uh, value for patient or survival for the patient.
Yeah. We accept the answer. Thank you very much. So with this, now other teams can ask questions to the participating teams. Team 1.
Sir,
No,
Tanvir
first
sir and Abha.
Dr. Tanveer Ahmed and Abha,
Sir,
the
sorry, sir.
other
Other
panelist.
5 minutes.
Panelists, there's 5 minutes time.
Other panelists have to ask question first.
Right. Sir, I'm really sorry. Other panelists have to ask questions.
Yes.
Dr.
Am
Tanveer
I
and Dr.
audible?
Abha.
Yeah, I think I'm Tanvir. Yeah, for the team 1. Okay, what is the common long-term complication associated with these facial burns that may require reconstructive surgery in future? What are the concerns of the facial burn here?
Sir, especially related to vision and oral intake. lower eye ectropions, lower or upper eyelid ectropions, and periolar burns are the concern in long term, sir, which will need reconstructive surgery.
Okay. And what is the common psychological impact observed in such patients with facial burns? What do you think?
So can you repeat the question, please?
The common psychological impact, usually we found these sort of cases.
So depression.
Yeah. Actually, what is the common psychological impact observed in patients with facial burns?
Decrease self-esteem and social anxiety.
Okay, the depression or the stress. So, in that case, what psychological support should be initiated early in such cases? Which measures will you take?
Sir, taking care. Yes, sir. Multidisciplinary approach should be done, sir. Specifically, when patient with facial burns comes to us, we should manage it properly. With if there are the deep burns, we should manage it properly with early excision. We should assist with various dressing methods to
Actually,
try
should I
to.
clear your psychological measures? What measures can be taken?
So the counseling of the patient is very important.
I think I have access the audio also, isn't it? I
Yeah.
also. Thank you so much. Huh?
Yes.
Okay. There's some problem in the set, I think.
So the counseling, psychological counseling
Yeah.
of the patient.
Yeah. Okay. Now over to Dr. Abha.
Good afternoon, everybody. So my questions are to team 2 or team 1?
Team 2, madam.
Yes. Okay, team 2. Already one question has been asked on aspect of this, but I would like to know what are the characteristics of a second degree superficial burns?
Ma'am, in a second degree superficial burns, since the burn is till the level of superficial dermis, so there would be blistering and there would be pain, pink and moist, and pain on touch, and the dermis, the sensation will be preserved, pain on touch, and the dermis will blanch on pressure, and
Okay, yeah,
the
I agree
upon
to it. You're correct.
uh,
So, yeah, tell.
on pulling the hair, it wouldn't be easy to pull out the. It wouldn't be easy to pull out the hair upon pressure.
Okay, but I don't think we would be wanting to pull the hairs, no, because it's very painful, isn't it?
Yes,
Okay,
ma'am, yes.
so the next question is, what is the whenever you're doing tangential excision in a patient with extensive burns, what is the upper limit which has been described in our textbooks which we can do? What percentage?
Around 20%, 10 to 20% has been described across textbooks. The upper limit described as 20% total burn surface area.
Yeah. And whenever we have and do any tangential excision, there is blood loss. So according to the percentage that would be excising, what is the approximate blood loss, or how much blood units would you keep ready for going before you go in for this tangential excision?
For every TBSA burnt that we excise, around 23 ml of blood loss is there. So for 20% TBSA burn, if we are excising, I would want to keep around 1 unit of 330 ml blood ready for transfusion post burns, post the tangential excision of burns.
I would say roughly it is around 300 to 300 ml per 5%. So to be on the safer side, because if there is blood loss and patient goes into hypotension and shock, we land in trouble. So keep 1 unit for every 5% burns.
Mm-hmm.
Okay, so now after you have done the tangential excision, in this patient, and grafts have all been adherent taken. What is the positioning of the axilla neck that you would be doing here? Any specific?
Neck, we won't allow, if we have grafted on neck, we won't allow the patient to use pillow. We'll keep the pillow below the shoulders for neck to be in extension. And axilla should be sprinted in slight abduction, in 90-degree abduction. And for hands, we use anti-deformity position initially with a wrist and slight extension, MCP joint in 90-degree flexion, and IP joint extension. And with groin for thighs and bilateral thighs in slight abduction position.
Okay, I think I'm done. Thank you.
Now,
Madam, now other teams are going to ask questions for the team. First, I would like to ask PGs from Bangalore Medical College, Team 3. Do you have any questions for this? PGs
Yes, sir, we have a question. The question is, can they talk about the IV index in burn resuscitation?
voice is breaking.
So, can you comment on the IV index in burn resuscitation? Something about the IV index? Hello?
The answer, just say no, they will answer. Okay, PGs from BMC. I think they don't know the answer. You just answer your question and we'll move to the next team. PGs from BMC. Okay, we will move to the next team. Team 4, Sage GS Medical College. Do you have any questions for the presenting team? Teams. Team 4, PGs from Sage GS Medical College. Okay, Team 5.
Hello? Are we audible?
Yeah.
Yeah. Should I repeat?
Yes. You are from?
We are from Bangalore Medical College.
Team 3, right?
Yeah, team 3.
Uh,
Was an answer audible?
you have to answer it.
Okay, so the IV index in burn resuscitation is a
being recorded.
fluid resuscitation volume of 250 ml per kg given within the first 24 hours after burn injury. Exceeding this volume will cause a lot of complications like abdominal compartment syndrome, acute kidney injury, and even death. So therefore, that that is the use of the IV index. Not to over resuscitate the patient.
Okay.
Yes. Thank you.
Thank you so much.
Thank you.
Any questions from Team 4, Sage GS Medical College?
Yes, sir.
Okay.
What is fluid creep?
5% D.
Can you be clear?
Compartment.
PGs from Sage GS Medical College.
Yes. Am I audible, sir?
Yes.
Yeah, my question is, what is fluid creep?
Fluid creep is a phenomena in which post-burn intravascular fluid is shifted to interstitial fluid, especially not only in the burned area but also in the unburned area when the percentage of burn is at least more than 25 to 30%. It is because of the inflammatory mediators which mediate inflammatory mediators that are released, especially histamine, bradykinin, and all serotonin, which leads to decrease oncotic and decrease hydrostatic pressure inside the blood vessel, so that there is a shift of fluid from intravascular to extravascular space that leads to edema over the burnt as well as unburnt area. It,
Hello.
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 PGs of CGS Medical College, are you happy with the answer or you want to explain it?
Yes, sir. I just want to add something. So the answer is correct actually, but the it is basically because of over resuscitation.
Okay, fine. Now moving to team 5, Jipmer Pondicherry. PGs from Jipmer Pondicherry, do you have any questions to ask?
Yes, sir. What are the methods to assess the depth of burns?
We can assess depth of burns clinically, as well as we can use laser or Doppler or dyes for the same.
Clinically, we can assess upon on the basis of blanching of the skin on pressure, on sensation on pinprick, and
Hair pull.
Hair pull.
Sorry to
As well
interrupt.
as from the appearance of the burns.
Don't drag the question. Answers. Just tell the methods because we don't waste time. Okay. You are over with your methods, right? Now, other team, do you have any more methods to assess the depth of the burns?
Technicians can be used for assessing. I would like to add.
PG from Jipmer.
Yes, they have told almost everything, sir, except for vital dyes can be used.
Vital
Biopsy
dyes
will be-
mentioned, ma'am.
I think something.
Vital dyes biopsy and ICG can be used.
Okay.
And light reflectance. These three things.
Okay, done. Next, any questions from Team 6 SMS Jaipur?
Am I audible, sir?
Yeah.
So what are the early indications for intubation in these kind of patients who are presenting with neck burn?
If the saturation is not being maintained, if you are suspecting inhalational injury and saturation is not being maintained on mask ventilation, then we would, we are suspecting severe inhalational injury, we want to intubate the patient. And
in cases of severe facial burns or in cases of circumferential chest burns, we go for early intubation.
Other team, you want to add something else?
Yes, sir. PCO2 value of more than 60 and PaO2 value of less than 40 is also an indication for intubation.
Okay. PGs from SMS Jaipur, you want to add few more?
I would want to correct the values. It's basically PaO2 of less than 60 mm and PaCO2 of more than 50 mm of Hg. And other indications would be congestion or soot at epiglottis, deep head and neck burns, stridor or respiratory distress, upper airway edema or erythema.
Okay,
So
thank you.
this is it.
Now, any questions from Team 7, Ames Rishikesh?
Can you please describe the unique characteristic of burn pain? Like what is the breakthrough pain and what is the background pain?
If you know the answer, you can answer. Otherwise, say no.
Yeah, like background pain is the pain which is at present.
Wait. There is other team also. Both teams, you can't answer this question. Okay, fine. You can
Yes. So the background pain, it is the pain which is present at the burns area or during the rest period. And the breakthrough pain is the pain which occurs during the simple activities like when the patient changes the position and the during walking and changing the clothes. Thank you.
I think, sir, it needs some correction, right? Usually burns pains are usually 3 types. One is background pain. Second one is procedural pain. Third one
Yes,
is
sir.
breakthrough pain. Background pain is usually due to burn injury, which will be a low threshold. It is throughout the period. Whereas the second one is procedure pain. When you do any procedure like dressing or any debridement of fasciotomy or something else. And the third one is breakthrough pain. This is because this is the in between the interval of any analgesia doses. That is breakthrough pain, I think. Sir,
Yes,
anyone want
it
to
occurs
add?
during the activities. Yes, sir.
Okay, fine. Now, team 8, PGs from AIMS BB, Bhuvaneshwar. Do you have any questions?
Good evening, sir. Am I audible, sir?
Yes, yes.
How will you measure the endpoints of resuscitation, the adequacy of resuscitation in this patient?
We can use urine output as a measure for the adequacy of resuscitation. That is, for adults, it should be between 0.5 to 1 ml per kg per hour. We can also use
Central venous pressure monitoring can also be used.
Okay. Other team?
Yes, sir. Sir, measurement of hematological values, specifically, we have to maintain hematocrit more than 35. That is also one of the indicator of adequacy of resuscitation. And more than systolic BP, mean arterial pressure is good indicator for measuring or adequacy for resuscitation. And yes, sir.
Okay. PGs from AIMS Bhuvaneshwar, you just want to complete?
So I think that is adequate. There can be invasive methods and non-invasive methods. Non-invasive methods, as they said, can be the urine output that is measured. And the invasive methods could be CBP monitoring or mean arterial pressure monitoring that they've already mentioned.
Okay. Team 10, PGs from BMCRI.
Yes, sir. What is the objective method to predict the mortality in burns?
Method to predict the mortality.
Can you say it again?
Is there any scope?
Hello.
Hello. Hello. Team 2.
Hello.
Team 1, PGs of BGMC Pune. You are saying something?
Yes. Yes, sir. Percentage of burn can be one of the indicator to predict mortality objectively.
Hello.
Yeah, you are clear.
Sir, am I audible, sir? I have some disturbance in the audio.
No, you are clear.
Yeah, sir. My question is, is there any scoring for predicting mortality in burns?
Yes, yes. If you know any scoring methods, you just say yes or he will answer that. Okay. I think they don't know the answer. You just answer it.
It's a revised box score where the mortality is predicted by adding the total body surface area with age. And if there's inhalation component, we have to add plus 17.
Now, any questions from KEM, team 11? PGs from KEM, do you have any questions?
Hello.
Yes, you're audible.
What are the indications of fasciotomy in this patient? Clinical indicators.
Clinical indicators for fasciotomy.
Yes, sir.
In case of limbs, if there is pain on passive flexion, if the capillary refill time is less, or if the pulses are not palpable, if there is if the extremities are cold, then we would want to proceed with if there is tightness upon
Paresthesia.
Paresthesia is there, there's tightness on palpation, we would want to proceed with fasciotomy of the limb.
Pain on passive stressing and circumferential burns are also indication for fasciotomy and especially constriction ring formation.
Team 11, KM, PGs from KM. You got your answer, or you want to further tell some points?
We got our answer.
Okay. Now, when last team, Team Gopal from MGMC. You have any questions for the?
Sir, I have a question, sir. What is Zurich skin and how many days does it take to engraft?
I think you can answer the question.
Sir, it is tissue engineered autologous dermoepidermal skin graft, sir, and it takes about 3 to 8 weeks to be engrafted.
Okay, done. Now we move to the moderator questions. I would like to request our moderators.
Oleg, can I join?
Yes, sir.
Dr.
Yes.
Chaudhary? Thank you very much. Well, at the outset, I must congratulate Madam Lakshmi and his team, our team, sorry, for all that arrangement been made. And one thing I have to tell to the students who are appearing, that this is not just a exam, but it is a competition. And in competitions, obviously, you are supposed to be very precise and to the points. And the panelists have asked you very good questions, in fact. I didn't have to ask much questions, but your answers should be very shortcut. Don't try to explain yourself, unless otherwise the panelists ask you in detail to explain. That is a point. So that makes the difference in your answer as time management is concerned. And few things, if I ask you one or two questions, it's a bonus question, I hope. Can you, any of the teams, team 1, what is Steven-Johnson syndrome and toxic epidermal necrolysis? That is SJS and 10. And it happens in burns. Steven-Johnson syndrome and toxic epidermal necrolysis. Have you heard about this? Have you patients, have you seen it? But theoretically, it is possible. And what can be the etiology for this? Team 1, Mrunal?
Yes, sir. Sir, gram-negative sepsis can be etiology for Steven-Johnson syndrome or toxic shock syndrome, sir. Especially when patient has sepsis.
Anything else? Anyway, doesn't matter, it's a competition. So anyway, a drug can also cause antibiotic, any of the drugs. It may be anticonvulsant drugs or any drug can cause also. Okay. And about the maximum fluid you can give to a patient, suppose it's more than 50%, it is about 80%. How much of fluid you'll give? How do you calculate in modified Parkland's formula? Suppose the patient is 80% body surface area burns. What will be your calculation for this patient in a modified Parkland's formula as far as the fluid management is concerned?
Modified Parkland formula will not consider 80% burn. Will consider maximum 50% of the burn to limit.
Why? It is 80%, so calculate 80%.
To limit overestimation of the fluid calculation.
The other team can go for the answer.
So 50% is the limit for calculation. As a modified Parkland formula, it tends to overestimate the resuscitation. So for as of total body surface area burns are concerned, we would limit our calculation to 50% if it is if the burns are involving more than 50% area of the
So
individual.
physiologically, it is not acceptable. Okay, more than 50%, even you go, you have to calculate in 50%. So one simple question was there: the depth of burns. How clinically you will know the depth of burns? How clinically you make out?
It's for team 2 or 1. The question. Question is for team 2.
Yeah, team 1. I mean team.
I think it is already been asked. The question is already.
Yes, what is the test name? By whose name it goes?
Jackson's zone, sir.
Very good. Okay. And I hope most of the questions are already been covered. I don't want to waste time. I have already finished 3 minutes. Thank you. Hand over to the next moderator.
Good evening. Thank you, sir. Good evening. I just wanted to ask one question, and this goes to Team B. And that is, there was a lot of good questioning about early enteral feeding. And there was also a discussion about why it is important. The patient, when you talk about early enteral feeding, the patients may not be able to consume that. Name 2 methods by which you can give early enteral feeding to the patient with a major burn.
Team B has to answer.
We can try early enteral feeding with nasogastric tube.
Gastric
And
tube, yes. Then
than that, we can go for feeding gastrostomy or feeding jejunostomy.
yes, correct. I'm okay. I'm okay. You got the answers. Good. Good. I think we can move on.
Now I'd like to request judges and patrons. Do you have any questions for the teams presenting?
Can I proceed?
Yes, sir. Yes, sir.
Okay. First, I would like to ask the question to Team 1 that what is the burn index? A simple clinical assessment. Have you heard of that or not? Team 1?
So the box index you're talking about.
Box index is calculative. You have to calculate 10 plus minus a simple on the spot assessment. Team 2? Any other team? The burn index is very simple. Clinically, you can assess just bedside age plus percentage of burns. If it is more than 1 or nearer to 1, the prognosis decreases. If it is more than 1, it is 0. Because age plus percentage of burn divided by 100. Extreme of ages are the exceptions. They are left. First question. Second, I have time now. Second question to Team B. 2. Would you like to change your opinion of management by seeing the right forearm and hand burn?
So it looks circumferential. Sir, it looks like a circumferential burn over right forearm. So
It is
in
deep circumferential burn.
yes,
Now,
so I
what should
would
be the management?
initially I would like to go for escherotomy by giving mid-lateral incision over forearm initially. If the distal vascularity is still not good, then I would go for escherotomy of fingers also.
So you will wait for development of something, or you will assess the thing, and in anticipation it will be better to go for fasciotomy or escherotomy.
If there is pain on passive flexion, then we would want to go on to fasciotomy after escherotomy.
Okay, Team 1 would like to add?
Yes, sir. I would like to add splintage if there is no compartment. If there is compartment, I would like to go for fasciotomy.
Okay. The main purpose is to get the complete release of the pressure. And at one go. You don't wait, otherwise changes will occur. Can I ask one more question?
Other judges would like to ask.
Okay.
Otherwise, you
It's
can
okay.
ask.
Otherwise,
I don't have any question, madam.
Okay. So,
Angelina,
what
madam?
is the abdominal compartment syndrome? Just this question.
It is any
For team
team
one.
can answer. Abdominal compartment syndrome. Partly it was answered by you people earlier.
So because of over resuscitation, the abdominal compartment syndrome develops, especially the pressure inside the abdomen when goes above 12 mm of water, which will require further assessment, or more than 12 mm of water with organ failure, or without if the pressure is more than 20 mm of water.
So, what is the best criteria for measuring it? Best method of measuring?
Sir, the catheter, measuring catheter should be placed inside a inside a urinary bladder.
So,
intravesical pressure.
Yes. Okay. Other people can ask.
So the question now should go to team B, because team A has got, team B should get one question.
Okay. So, Dr. Selva, ask the question.
By whose name does the tangential excision go to team B?
Zora Zanjikovic.
Okay.
She was a yoga
pioneer.
On which day you would like to do the tangential excision?
From 3rd to 5th day, in a window of 3rd to 5th day, I would like to go for it.
Okay, right. So we have given equal chances to both the teams, 1 and 2. So any other questions?
Sanjeev Uppal sir, do you have any questions to teams? I think both teams got the judges' questions. Any other faculty from seniors? Apbc team or faculty from the audience? I ask one question. If the facial burns and develops the contractures or the facial burns scarring, what is facial stigmata? What is facial stigmata? From where to where it extends? Is the face classified or depending on that?
It is ectropion of upper or lower eyelid. Then in nose, it is either stenosis or alar flaring. In oral cavity, it includes microstomia.
Yes.
And severe microstomia or ectropion of lips.
Yes.
And severe contracture of neck.
Yes. So it extends from the lower eyelid up to the neck. So can you tell me the completion? How will you classify the face scarring? They based on the stigmata? How many types of faces are there based on that? There are 2 types. Okay. If there is no deformity, it's only scarring, it's type 1. And if there is any deformity, it's a type 2. Okay. Team 1, if upper lid and lower lid both are having scars with ectropion, which one will you address first? And what type of resurfacing you recommend? Team A?
Ma'am, both upper and lower eyelid are involved, right?
Yes. How will you correct them? What is the sequence? What is the first thing to do, and what type of resurfacing?
Ma'am, ectropion release, especially incisional release with STHG. I will like to go for lower eyelid ectropion followed by upper eyelid ectropion.
You'll release lower eyelid first.
No, upper eyelid followed by lower eyelid because it covers major surface of the cornea.
What precaution you take? How will you assess adequately released or not? Team B?
Ma'am, I would like to do incisional release of and overcorrection of the contracture
Yes,
of upper
wonderful.
eyelid first, followed by resurfacing with medium thickness skin graft, followed by after 3 to 4 months, I would go for lower eyelid ectropion correction by incisional release, followed by resurfacing by full thickness skin graft.
Yes, that is the complete answer. Half marks only you people will get. Right. I request the judges, better you give the marking at this juncture for the spotter one. So there will be little. Would you like to give marks for teams now, sir, after spotter one?
Somebody has kept the calculation, or we had to done? That was not clear.
Yes, sir. Judges only mainly take care of this.
Okay. So
I told
we will give
Salvaras
it to, we will give it later on. We can go to spotter 2.
Spotter 2.
Can I?
Team 1.
Team 1, 21 and 23.
Dr.
Team two.
Venkataraman wants to say something.
Lakshmi, just 1 second. Team 2, you said superficial dermis. Is there any name for that?
The papillary dermis, sir.
Exactly. Go ahead. Yeah, go ahead, Dr. Lakshmi.
Now the spotter 2. So primary panelist Dr. Tanvir Ahmad. I invite him to start the thing. And Dr. Devi Mahapatra. These both will ask questions for 10 minutes. And initial questions will be addressed to the team 2. So that is team B first has to answer. Dr. Tanvir Ahmad, kindly ask your questions.
Just background, madam. Give a background of this patient.
Yeah, definitely,
Just
sir.
a second. Just a background for the students. So this is a patient who underwent this kind of burn injury. He is a non-diabetic and he had this burn injury during a religious ceremony. So that is the background of the patient. Dr. Tanvir, you can please proceed with the questions.
Thank you. Okay, are you ready? So you are seeing the patient. So what do you think? What is the approximated depth of the burn seen on the sole of the foot?
It
Team
is
B.
second degree superficial burns involving sole of foot and with preservation of instep area.
Okay, the next team.
Team A.
What do you think?
Third degree burns.
Okay, you are thinking for the third degree burns. Let me Usually the sole of the foot, it usually be the deep partial thickness of the foot thickness burns usually happen. So it is deep partial thickness burn. What is the recommended approach for the large intake blisters? You are seeing there is a small blister, but if there is a large blister, what will be your recommended approach for the large intake blister?
In palms and soles, we don't deroof the blisters as it is quite painful. So I would go for puncturing the blister and
basically not to deroof the blister. We would like to go for needle aspiration so that we could take out the blister fluid as it could get infected. It is tenacious and
Yes.
yeah.
Okay, if it is not been organized, so you can actually expel it out with by syringing. If it becomes organized, what can be done? The blister fluid becomes organized.
Then we would go for deroofing of the blister and we would manage it
Yeah,
as a
correct.
part of the burn wound.
Correct. Correct. And can you please name one advantage of the tangential excision in this plantar burn?
So advantage, sir.
Yeah. Why actually we used to do the tangential excisions? The next thing.
So to prevent contracture in future.
What is the advantage of tangential excision in this case?
Early resurfacing of the wound and preventing contracture in future.
Okay, but what is the actually what we used to do in the tangential excision? How to excise? What are the thickness? What are the tissues to be excised in the tangential excision?
We remove layer by layer so that till we get the healthy bleeding points. So it would prevent over excision of the tissues.
Yeah, that means it will
And it would
preserve some
prevent
tissues.
contour deformities.
Okay, and if you are not actually, for example, what name one complication likely if proper offloading is not done. That means proper excision was not done. What will happen?
Contractures can develop if the wounds are not properly managed, and if they are if more excision is done, then contour deformities can develop.
If inadequate excision is done, what will happen?
Inadequate. In case of inadequate excision, sir, we risk loss of the graft if it is to be followed by graft resurfacing.
The next thing.
The healing will be delayed for the patient.
Which region the delay? Yeah, healing will be delayed. Why?
Sir, weight bearing area. Patient is also diabetic. We are also left inadequate. We have done inadequate excision.
That means inadequate excision. Actually, in case of inadequate excision, there will be remaining part of the dead tissue will be there. Okay. So after the adequate excision of this wound, what can be done?
The wounds can be resurfaced by split thickness skin graft, or we can also use dermal matrix followed by split thickness skin graft application.
Okay, correct. And what is the what is the next best step in wound management after initial debridement? So you will go for the skin grafting, or if it is more deep, you want to apply the dermal matrix followed by the skin graft. Am I right?
Yes, yes, sir.
Which type of dressing you want to put?
Sir, now go to the team, other team, 5 questions you have asked
Yeah.
for this team. So go to the
Okay,
team
thank
one.
you. Okay, now I would like to pass to my co-panelist, Dr. Devi.
Yeah. So my questions will be for the team one. Okay, so with the background what you got for this patient is a diabetic with this kind of burn injury. What specific investigations would you like to do pertaining to this patient, which will help you in your management?
So the ankle brachial index and the Doppler of lower limb.
And sorry, could you repeat again?
So the ankle brachial index and the Doppler of the lower limb to know about the arterial status of the patient since he is being diabetic. I would like to look for microangiopathies, especially which will hinder wound healing.
Okay, what other test would you like to do?
HbA1c,
Correct. Anything else?
lower limb, bilateral lower limb angiography.
Any common test which you do regularly for diabetic patients? What are the problems do you anticipate in this patient?
Sir, peripheral neuropathy and wound healing will be a problem for the patient specifically.
Yes, correct. And do you expect any renal anomalies or renal problems in diabetic patients? Would you like to do some test to rule out those pathologies?
So the kidney function test specifically.
Correct. So basically, you're doing HbA1c, kidney function test, and ankle brachial pressure index. Can you tell me what value of ankle brachial pressure index would make you cautious that something is wrong? Can't hear you.
But less than 0.3.
Less than 0.3 indicates what?
Arterial thickening, or what you say?
Team B, can you give a
Critical
better answer?
ischemia, less than 0.3 value points towards critical ischemia.
Critical ischemia. Critical ischemia is less than 0.3. Okay. Then in the initial management of this patient, what kind of dressings will you prefer when the patient comes to you first? What would you do? In the initial management, how do you proceed with the initial dressing? The patient comes to you with this kind of injury, how do you proceed?
Sir, I would like to do dressing with non-adhesive dressing for the patient.
Okay, a little bit systematic answer would be better, na? Like this patient comes to you, you are doing a first dressing. Would you immediately put a non-adhesive dressing? Would you do something and then go for something? Shall we take to team B? Can you give a better answer?
So I would go for colloidal silver ointment mixed with antibiotic ointment, over which I'll apply non-adhesive gauze and cover the wound.
Okay, I would have expected a little bit of debridement, initial debridement,
followed by back
thorough wash, followed by non-occlusive dressing, and absorbent dressing. Would have been a more acceptable answer. Okay.
Sir,
We'll
what
give
is
it.
the mark you want to give for both the teams? Because the
Okay.
primary is for the team.
Primary team, we won't say it half mark only. I would like to give them. They can give the.
I think they should
proper
be
answer.
given 1 mark each.
Yes, sir. Yes. Okay.
1 mark each.
Okay.
Okay, sir.
Sorry to
Then
interrupt, sir. Now we'll move to the other panelists, sir.
yeah.
Questions.
Please,
Would like to request Ramakan sir and Abhaman to
Yeah.
ask questions.
Team one, what do you think the basic question that is burns blisters are traitors or faithfuls? Advantage or disadvantage?
So can you repeat the question, please?
Burns blisters are of advantage or disadvantage? Faithfuls or traitors? Again, I will clarify.
Yes, sir, I got it, sir.
Yeah, tell me the answer.
Sir, in early phases, we have advantage that if we have advantage of anatomical skin cover, so that fluid will not be evaporated. So basically, we just aspirate it. So that is the advantage of that. But if eventually if get infected, we need to de-roof it. So that is being the disadvantage of the blisters.
Other team, can you answer? I don't accept this answer. The second team.
The advantage of bursting blisters is sorry.
Is it advantageous or having disadvantage to have blister?
Overall, it's a disadvantage to have the blister.
Yeah, perfect,
Yes.
perfect. There ends the answer. Now, team one, tell me 5 causes of blister having disadvantage for wound healing. Why blisters are not good?
Sir, since blister is there, so it will be a second degree burn. That is, burns will be deeper. The second, the content of the blister is toxic, which will hinder with the wound healing of the patient. And there will be loss of intracellular fluid, which will aggravate edema, which will aggravate edema over the burnt and unburnt area. And if it get infected, we need to intervene into that. It will be a source of infection to neighboring wound.
Anything else? Your one answer is correct that it impairs the healing because of its contents. I asked for 5 reasons. Can another team tell me another rest 4 reasons why blister?
Another reason is since it is a proteinaceous fluid in the blisters, it will cause infection of the area and will deepen the degree of the burn.
I think I should answer. Number one, because of blister, we cannot determine the appropriate treatment because the depth of burns is masked. Number two, because of blister, the immune function is hampered to defend against infection. Number three, if there is uncontrolled blister rupture, there can be a prolongation of healing and infection. Then number four, due to impaired microcirculation because of its own pressure, there is a risk of burn depth progression. Also, if it is on joints, it impairs the mobility of the joint. And definitely it impairs the penetration of topical antibiotic. These are 5 reasons why blisters are not good and they should be de-roof. Puncturing and aspirating is not advisable as per the international protocols. Should I go with the next question?
Yes, we are not giving marks for both the teams now.
Yeah. What are the practical difficulties of immediate grafting after tangential excision in this plantar burns? Just like in other areas, we go for immediate excision and grafting. What are the disadvantages or problems on plantar surface?
Is it for team 2 or team 1, sir?
Yeah, team 1.
Sir, the sole being the weight-bearing area, so post-operative splintage will be difficult here. Then the area is since the sole burns are there, there will be what we say, the surface is not even here, and since the patient being diabetic, it will hamper the acceptance of the graft at this place, especially because of paucity of blood supply. and microangiopathy.
I think can other team tell me the answer, expected answer? It's regarding the bed after excision of the wound. What is the disadvantage?
If tangential excision.
So that bleeding
Yeah.
will be more after tangential excision. Yeah.
In case of
The
permanent.
correct answer, what I expected in practically, because plantar surface is having fatty layer beneath the skin, which is not well vascularized. So the chances of graft take after tangential excision on plantar surface are poor. That is what I expected. Thank you. I think the next panelist can ask the questions, Dr. Devi.
Abba, ma'am. Abba,
So
ma'am.
my
Abba, yeah.
So my questions are to team 2. So in this patient, we see that if you see it's the percentage wise, it's quite less. But then foot burns, we would want to admit the patient and do the needful. Give 2 reasons for that. Why do we have to admit this patient?
As it involves a important area, weight-bearing area of the.
Sorry, I thought it was for team 2.
Yes, ma'am, I'm team 2.
Okay, sorry. Tell.
It involves weight-bearing area of the patient, so which needs to be resurfaced properly so that it will later on help in ambulation of the patient. And
Yeah, so if the patient is not admitted, what happens?
the burn wounds can get infected, and
Patient is
it can
walking all
also
over the place.
uh,
There is no elevation, there is edema. And because
more
of
edema will be there, and yes, ma'am.
it will hamper
And
wound healing. In what ways? We admit the patient, do the primary dressing after the debridement cleaning, and we put the patient on the bed and advise the patient to be on the bed with strict lower limb elevation so that the edema fluid is not collected there, and then there is nutrition and vascularization and oxygenation to the periphery also, which happens properly, and wound healing happens faster. Okay. So the next question is a general question again.
Madam, go to team 1 because team 2 has got a question. Team 1 needs 2 questions.
Okay, ma'am. So team 1, my question is, in any patient, burn patient who comes, or nutrition is very important for any patient for wound healing, correct? So what are the markers that we use? Do we do any investigations to test the level of nutrition?
Yes. We do the initial investigation such as CBC, complete hemogram of the patient, so as to evaluate the hemoglobin levels, and we do liver function test in order to find out the serum albumin and serum protein levels of the patient.
Yeah, okay, I got the answer. So the next question in continuation is, when a patient comes to us in the initial stages of burns and a patient has hypoalbuminemia, in addition to the wound healing, how does it affect? How is the patient affected by the hypoalbuminemia during fluid resuscitation?
There is increased chances of fluid creep in such patients because of uh, 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 because of imbalance between the stalling process and the resuscitation fluid will be will go into the interstitial spaces.
Yeah.
Decreasing in intravascular volume.
Yeah. So, and the last questions I would like to ask is, patient with extensive burns during a phase of hypovolemia, maybe after a surgery, excision, tangential excision, most of the time during that, whenever we have put our allograft and patient goes into shock and patient is put on vasopressor, why is it not good for the wound healing?
Yeah.
For team one or two questions.
Vasopressors primarily lead to the constriction of the blood vessels which supply to the skin, which as we have placed the allograft, the nutrition to the allografts will be hampered and lead to the loss of the allograft.
Yes, so we always have to make sure that, with discussion, that the vasopressors are discontinued as soon as possible. Yeah, thank you. I think the number of questions are done.
Now it's moderator's turn.
Hello.
For the next spotters, the PG questions will not be asked due to shortage of time. I request the moderators to take over.
Yeah, thank you, ma'am.
Now the question should go to the Gangaram team. Moderator.
Hello.
Team 2, the questions will be directed to team B.
2. It will be team 2.
Yeah.
So can I go ahead, madam?
Yes, sir.
Yeah. Well, we are talking so much about tangential excision, and we have discussed about it. But I wanted to very shortly, by Mrunal, what are the advantage of this tangential excision, and when it was first done in which year? Do you have any remembrance of the year?
In 1970s by Zora Janzikovic, sir.
Okay. So what was the first procedure done by her?
Small excision, small.
What is the first
tangential
procedure?
excision?
Okay.
Small tangential excision was done by her. Small
Then?
area of tangential excision was done.
Yes, then?
Followed by that,
then autograft was placed on that. That is done in the first time. Okay. So what is the advantage of tangential excision or the early excision, whatever you call?
The tissues are removed layer by layer, so that we don't over excise the healthy tissues also.
No, you have to buy it. It should be like that. When you are doing it, it is why you are doing it. You are doing for decreasing the inflammatory mediators or abating all the burn inflammatory cascade. You are breaking it. Okay. And we have a quicker healing that will be done. And the total procedure will also reduce the wound sepsis, and it will also reduce the threefold mortality rate also. And there will be the stay of the hospital will be lessened, and there will be a quicker healing of the wound. And obviously
Sir, questions, sir, kindly ask the questions first.
Yeah. Then I tell you what you mean by early excision. That point I want to very sure.
Early
By
excision means
one.
early tangential excision would mean excision from day 3 to day 5. So that
then what is ultra early and what is early then? It is a time in hours, not in days.
in less than 24 hours is immediate.
Yes.
Ultra early.
Yes. Then what is early then?
Day 2 to day 5, sir.
Yeah.
And day 6 to day 16 is delayed, sir.
Okay, you are near about correct, I think. Exactly, it is early means from 24 hours to 96 hours. And below 24 hours is the ultra early. And then after 96 hours, it became a delayed excision. Okay, I think Dr. Karthikeyan, you can take over.
Yes, sir. Now, my question is to team 1. There are 2 parts of the question. The first part is, apart from the deep wound that you can see on the anterior aspect of the sole, on the posterior aspect, you can see a whitish area. What do you think it represents on both feet?
Represent Jackson zone of stasis.
Of?
Stasis. Stage of stasis.
Okay, spasm. Okay. So you think that is also involved, isn't it?
Yes.
That is also involved. So you need to take care of that also when you are managing the primary wound, right?
Yes.
And second part is, then this patient, you're going to put a skin graft for this wound because it's a deep dermal wound. Now, after putting a skin graft, what sort of footwear would you advise for this patient? Or would you need any footwear or not? Specialized footwear or not?
So post-operatively, we will do immobilization. When the graft uptake is there, we will go with footwear modification for the patient.
What footwear modification? That's what I'm asking.
Especially offloading of the involved area with thick sole.
So where do you want the weight to be borne in the modified footwear? What is it that you want to avoid? You want to avoid weight where?
Over the graft area, sir.
Over the anterior portion of the foot. So what is the anterior portion of the foot? What is the pressure points there in the anterior portion of the foot?
So the head of metatarsal.
Very good. Head of the metatarsal. So you want to avoid pressure on the head of the metatarsals, isn't it? So your footwear should be given. How will your footwear be given? You want to avoid pressure on the metatarsals. So where will the pressure now be given? You cannot give it on the head of the metatarsals. Where will you concentrate on giving pressure? Yes, team B, have you an answer to that?
Sir, we would like to redirect the pressure towards the instep area, as that is the uninvolved region, and
correct. And the heel, posterior heel, right?
Posterior heel. Yes.
Those two are not enough because the anteriorly you will not have a balance. So you have to give it to the toes also.
Toes.
Right?
Okay.
So
Okay,
that is how it should be given. Right? Have you got that point, team 1?
Yes.
Yeah. Thank you. So I'll be giving 2 marks for team 1 and 1 mark for team 2.
Now time is for judges. They can ask the questions.
I should ask to team 2 first. Huh?
Yes, sir.
What type of burn it is?
This is a second-degree deep burn involving the
What type of the cause? It is thermal, electrical, what?
thermal burns.
It is thermal burns. Have you read the history of this patient as given in the spotter first? Dr. Lakshmi, you had given the history, no?
Dr. Mahapatra told, sir.
Dr. Devi have given. Dr.
Devi
Devi
has told.
Oh, you know the history.
He's a diabetic.
So what must have
neuropathic
caused?
patient.
He is a known diabetic patient, suspected neuropathy. So what may be the cause of this type of burn?
The foot of diabetic patients are insensate due to neuropathy, so he might be walking barefoot, and which would have led to thermal burns.
What is that type of burn called? Team 1?
Contact burn, sir.
Contact burn. Do you think it is electrical?
No.
Sir, this is a case of firewalk, religious walk. That's what the history says.
No, it was not firework. It was a long walk. It is frictional burn,
Frictional,
as
sir.
given in that your history. You just go to the history of that spotter.
Oh, we
He
give the
went for some religious purpose, walked barefoot for long duration, and developed this.
Yes, sir.
Actually,
Because
I
of the
think it's a
neuropathy.
walk on a hot surface, long walk on a hot surface
Oh,
in
on
a
the road.
religious. Yeah.
On the road, basically.
Yes.
Okay. So why did he get burned? Only one second question. Then the other judge can ask. What may be the reason?
The foot is insensate.
That's okay. Then how can
And
you prevent that?
shearing forces while
So
walking.
what is the first symptom of any such burn or friction or abscess in diabetic patient with diabetic neuropathy? Pain or anything else?
The pain is not there, so the patient won't be aware of the burns caused.
How will he detect? First thing to be noticed by the patient is
any wound over the foot.
Team 1 can modify this.
The swelling over the foot.
No, it is some spotting on socks or clothes or something that you have some wound there. Usually. Second judge.
Sir, do you want them to be given any mark for this?
They can be given one mark.
Okay, sir.
Equal.
Partially they have answered.
Okay.
Other judges, please. Dr. Vijay, sir?
No questions, ma'am.
No questions.
Can I move to the next portal, ma'am?
Dr. Neela Bhattacharya, are you available? Would you like to ask any question?
Ma'am, I am there. Good afternoon.
Yeah. Please ask some questions to the pages. This is your spotter.
Yeah. As the judges actually rightly said, this is can be called a friction or even a sunburn, because he walked on a long in a temple, taking his mother in a wheelchair, and did not notice. Even when all others around him were saying that the soil is hot, he did not feel anything, and he kept on walking, and realized that the soul had become like that after he finished the walk. Now, but classically, when you say sunburn is a first degree burn, whereas in this patient with a complete neuropathy, it is going to be much deeper than that. Now, the PGs, so that is one thing. Modality of the burn is very interesting in this patient. What I would like to ask the PGs, I think, which team? Is it team 1 or team 2, or both of them can answer that? I don't know. What are the dangers in a diabetic, especially? He's a young man, 43 years, but he's got such severe neuropathy. What are the dangers of such a burn in a diabetic patient? Can you just tell me that?
There could be delayed wound healing in diabetics, and due to microangiopathy, graft leak also wouldn't be good, as decreased blood supply.
And repeated trauma is possible.
Later on, you're talking about. I'm talking about the now when he's presenting to you with this particular burn. If I have to tell you more history, there is swelling of the foot also, and there is fever also. So why do you think these things happen to this burn in this patient?
As the patient is diabetic, he is more prone to developing infections of the wound, which will deepen the degree of the burn.
Can I add up one thing here, Dr.
Neela?
Dr. Neela?
Yes, sir.
We can ask the classification of this diabetic foot. This comes into diabetic foot.
Exactly. Exactly.
So can you tell team 1 or 2, whosoever is answering, the classification of a diabetic? Do you know about classification or not? No. Team 1?
Weakness.
Team 1? Okay, there are various classifications like Wagner's, Brodsky, and
International
University of Texas classification. They all depend on status of ischemia. So the ulceration without any deep tissue involvement, then deep tissue involvement, then some joint and bones involvement with infection or abscess, and then local gangrene and systemic gangrene. These are the 5 gradings.
So in a diabetic with a burn like this, you are going to think of those terms in addition to just a normal burn management. And therefore, it is so very more important that you admit and aggressively manage. He came with a blood sugar of 400 plus, HbA1c of 14.6. So diabetes had to be aggressively managed, strict bed rest, limb elevation, all those things had to be done. And we went in with not only a burn mat, that is, we applied hydrophilic foam dressing so that we were continuously removing the moisture and allowing the granulation to form from inside. But we also used something specifically used for diabetic ulcers. If you, I don't know whether you've heard of esmolol for diabetic ulcers. Have you heard?
No,
Teams?
ma'am.
Okay. So that is a new drug, which is esmolol is basically a beta-1 blocker, but now it has been extensively found application in diabetic foot ulcers because it is known to locally enhance the inflammatory mediators and the granulocytes, fibroblasts, keratinocytes, etc., endothelial cells, and cause wound healing. Okay, significantly reduced, increased wound healing and lesser survival of the limb is much better. So that is what was instituted for this patient and managed. Now, actually, the sole is a deeper wound. It's actually deep. So anything else would you like to do? Maybe if the next picture Dr. Lakshmi puts, then maybe it can be a little more.
Neela, as time is short,
yeah,
I'll just show that figure after completing the other 2 spotters.
Fine, madam.
Discussion.
Okay. Yeah,
Okay.
that's fine.
Thank you. Thanks a lot.
Okay.
Spotter 3, the panelists are Ramakant Bemde sir and Dr. Abha ma'am. I request them to start and PG teams, please answer crisply. So we are getting late.
Yeah, team 1. The first question is why the burns on hand are more common?
Team A, please answer fast.
Sir,
Otherwise, it will go to team B.
sir, hand being most commonly involved first in handball because that is what we use for fight and flight time. This is the only thing which comes first.
Yeah,
we are involved.
correct. Team 2, which part is more vulnerable in deep burns of hand in adult? Which part of hand is more vulnerable?
Dorsum of the hand is
Yeah,
affected more.
correct. Team 1, which part is more vulnerable in children?
Palmar
In
aspect.
hand.
Palmar.
Yeah. Team 2, what are the technical challenges of tangential excision in deep burns on hand? What are the technical challenges of tangential excision in hand?
So one is the dorsum of the hand has a thin
Yes.
thin skin,
It could lead to exposure of tendons and also the
which will eventually need flap cover in that case.
Perfect. Team 1, what are the various options for early debridement of deep burns on the hand and fingers? What are the options?
Tangential excisions with early fasciotomies and simultaneous management of extensor and simultaneous management of both wrist and
Techniques I'm asking. Techniques. What are the different techniques? One, you're told tangential excision using dermatome. Number two,
splintage, negative pressure wound therapy can also be used.
debridement, techniques of debridement.
Sir, chemical enzymatic debridements.
Perfect. Third,
Surgical debridement.
second team. What is the third?
Enzymatic, surgical, and
Enzymatic already he has told. Tangential he has told.
Anything else?
Hydrosurgery. Third is hydrosurgery. Hydrodebridement or Versagate, you can say.
Versagate.
Yeah. And team one, what are the advantages of using Goulian knife as you've seen in this picture for burns excision? What are the advantages?
So the small area of the fingers are easily tangentially excised. Unnecessary other areas will not be excised or unduly removed. Then precision will be there, sir. And both the aspect of the palmar and the volar aspect can be dealt properly, especially in fingers and hands.
Yeah. Perfect. This allows, being it is a small blade, it allows very precise, controlled excision. So underlying tendons and joints are not exposed. Perfect. Second panelist can ask the next questions. I have asked 5 questions.
Dr. Abha,
Yes, ma'am.
please ask questions first.
For
Yes,
team two,
two.
madam.
Team
Team
two.
two.
Yeah.
Team two.
Okay, team two. My question is, when you're doing the tangential excision of the hand, what is the choice of wound cover?
if it is the dorsum of the hand and if we end up exposing the tendons, then and the neurovascular structures, then I would want to go for a flap cover. If that is not the case, I can opt for skin.
We can also go for dermal matrix fortified skin grafting.
I would want to know whether we would opt for if the tendons and nerve endings are not exposed, would you want to put allo or a autograft, and why?
I would want to opt for autograft, ma'am. So
Why? What's the
allograft.
reason?
Ma'am, if it is not extensive burns, then autograft is a better option. An allograft will undergo a rejection after 10 to 14 days, and it will also increase locally. It will increase the inflammatory mediators, which might.
Yeah. So the thing is that we want the hand wounds to heal faster, so that the mobilization can be started. Correct. So that's why it's preferred that we put autograft on the hands rather than allograft if it is, we have the options or we have it. Okay. A patient comes to us with compartment syndrome and it is extending onto the hand. How do you address it? There is edema, tightness. How do you
Fasciotomy at the earliest for forearm and hand of the patient.
Okay, exactly. How do you do it?
I would like to go for incision over forearm flexor aspect. I'll also release the carpal tunnel. I'll also release on dorsum of hand with 2 incisions in second and fourth intermetacarpal space, and I'll also give fasciotomy incisions over radial and ulnar aspect of fingers.
Right. Okay. In hand burns, when do you see a botanier deformity and why?
This is for team one. Team one. So 5 questions are over for you. Team one.
Team one, in hand burns, a patient is developed botanier deformity. Why would it happen in which situation will it happen?
So involvement, deep involvement of the finger, specifically at the MCPs and IPs with
Okay, those team 2, do you want to answer?
If there is a injury at the level of PIP joint over the dorsum of the hand, that is the zone 3 extensor tendon region, I would be the patient might go into Britania deformity.
Why
As the
is it so?
skin is thin and
Yeah, look, but why is it so? Like,
Because
what's the mechanism?
Because of the volar subluxation of the lateral bands at the level of PIP joint.
Yeah, correct.
as well as central slip rupture could also be contributing factors.
Okay, whenever we are immobilizing the hands, what is the best position?
Is it 14 1?
30 degrees.
Now it
I
is team
think it
2.
is team 2.
We immobilize in anti-deformity position with MCP in slight flexion around 15 degrees, with wrist and slight flexion of 15 degrees, MCP flexion of 90 degrees, and IP joints extended. Along with we also give hand elevation to decrease the edema.
Okay, I would prefer the wrist to be in slight extension rather than flexion.
We meant extension, ma'am. Flexion. Sorry. Ma'am, it is extension, ma'am. 15 degrees extension. Wrist.
Okay, the next question is
to team 1. Team 1.
Okay, team 1. The next question is, we are immobilizing the hands and we use different kind of splints. So what is a cock-up splint, full cock-up, and what is a half cock-up?
So, ma'am, there is difference between angulation at the wrist for full cock-up and incomplete cock-up, especially just 15 degree of wrist extension with slight flexion as MPs and extension of IPs will be incomplete cock-up. For complete cock-up, there will be more than 30 degree of MCP, more than 30 degree of wrist extension, and the rest will be same.
I will not agree with this answer. So can the other team attempt it?
Ma'am, there is a difference in the position of the interphalangeal joints in the two splints. If in a complete cock-up, along with the 15-degree extension at the wrist joint and flexion of the MCP joint, there is also extension at the level of interphalangeal joints. While in incomplete cock-up, it does not extend to the interphalangeal joints.
Yeah, so it is up to the metacarpophalangeal joints, and it should be proximal to the joints so that the mobilization can be done. Okay, now the wound, it's not in an acute setup. The wounds have healed and patient has got a contracture in the first web space. Can you name a very typical flap that is used to release the contracture of the first web space?
This is team 1.
Okay, what are the options that you would be using in a first web space release?
Groin, we can do it by incisional release of first web space followed by groin flap, or a dorsal-radial artery perforator flap, or we can also do it by the Z plus T or square flaps.
Okay, whenever we would be using, sorry, can the other team answer the question?
I would first like to go for 5 flaps at plasty for release, followed by release of fascia of adductor pollicis muscle and
Yeah, it's okay. I wanted that answer, the 5 flap. The thing is that the other team, we wouldn't want to go in for a flap immediately. It's on the hand. Only if local flap coverage is not possible and graft is not possible when tendons and nerves and important structures are exposed, then only we would be going for a regional or a free flap. Otherwise, we would be opting for a local flap. Okay. Ma'am, more questions I need to ask?
Over, ma'am.
Okay.
Thank you. Both have got equally 7 questions.
Yeah,
madam.
yeah. So the next panelist, Dr. Tanvir Ahmad and Devi Mahapatra, can take over and ask the questions.
Yeah. Thank you. We discussed much about the tangential excision. However, can you please tell which team?
Team A.
Team 1.
Team A. Okay. What complication can occur if excision is taken too deep in the hand?
Can you repeat
Team
the question,
A.
please? Tangential excision should be?
Yeah. What complication can occur if excision is taken too deep in the hand? What will happen if you exercise deep?
Sir, injury to the underlying structure, especially the neurovascular bundle or the tendons, will be injured, sir.
Excellent. And now, can you please tell what is the ideal time window for tangential excision in major burn?
Ideal time for tangential excision in major burns.
Yeah.
So 3 to 5 days.
Ideal time, 3 to 5 days.
Early.
Okay. For example, you don't have the Persajet, but you are working in a setup and you are dealing with a forearm burn with Eshka or this sort of burn. So what alternative instruments can be used for tangential excision besides this Boolean knife?
Team B. Team B.
Silver knife can also be used, and
Humvee's knife
Humvee's
can be
knife can
used.
also be
Yes,
used, and
Humvee's knife
dermatome can also be used.
Excellent. Okay, now we'd like to over to Dr. Devi.
Yeah. Thank you. My question to team B.
Team B.
B, yeah. So this you just told about alternate instruments. Can you tell one more instrument where we use a regular shaving blade to do
Silver knife, sir. We mentioned silver knife, sir.
Silverman, very good. Silverman's knife, very good. Okay, one more question to team B also. Specific to hand burn, can you are you aware of any specific dressings which have facilitated hand burn management specific to hand burns?
We are aware of BioBrain gloves.
Various?
BioBrain gloves, sir.
Something specific to hand burn we are expecting the answer. Team A,
Glove dressing, sir.
I couldn't get you.
Glove, BioBrain glove dressing.
Yeah. Full BioBrain is a trade name. Can you tell the composition or something like that? You're right, on the right track.
BioBrain has two layers. The outer layer is silicone and inner layer is nylon mesh impregnated with collagen.
Silver impregnated microfiber gloves for hand burns. Okay, you are correct.
Yes, sir.
Then only one more question to team 1. How does the knowledge of Jackson zone help you in like limiting the extent of burn injury? How is the concept helpful?
Yes, sir. So the zone of coagulation will be removed. So we will not go for zone of stasis because if you remove that, it might be a good. It might eventually heal. So zone of coagulation, stasis, and hyperemia of Jackson zone will help us to remove only the only limited zone of coagulation, not the stasis or hyperemia.
Okay, we accept your answer. So our aim is to not to increase the zone of coagulation so that the remaining areas heals on its own. Okay, that's all from my side.
Now I invite the judges to ask the questions.
There is no question.
Sorry.
Dr.
Moderators are there, sir.
First
Moderators time. Okay.
Yeah, moderators, shall I ask a question?
Yes, sir.
First,
Team 2. Team 2.
Team 2.
Team 2. The
B.
question to you is, can you tell me the important points when applying a dressing for this particular patient after your surgery?
We want to splint the hand after the surgery. We
I'm
would
talking about the dressings.
We would like to separate the fingers with gauze in between the fingers.
Good. Point number 1. Then
Then
we would like to keep the thumb in abducted position.
thumb in abducted position.
yes, what abduction? What are the different types of abduction you can keep the thumb on?
Palmar abduction.
Palmar abduction and pronation.
Two types.
What different types of abduction can you place the thumb in?
One is
You said
palmar abduction.
Yes. Then what else? What are the?
And there is palmar abduction.
What other type of abduction is there?
The two types of abduction are there. One is palmar, the other one is.
Other one is, I'm showing you. This is palmar abduction.
Yes.
What is this?
Lateral.
Okay. Right. Now, any other point you want to add? You want to keep the thumb in abduction, then you want to keep dressings between fingers, gauze. Third important point.
I would want to give a ball of dressing in the palm of the hand, and so that
the fingers don't go into contraction.
Okay, you were talking about splints anyway, no?
Yes, sir.
Yeah. Okay, you want to keep a ball of wool or padding there, isn't it?
Yes,
okay.
sir.
So I'll give them half the points. And does the team one want to add anything more?
No, sir, only splintage.
No, I'll come to splintage. That question is for you. What splint will you apply for this particular patient? It seems to be a very small child. They've already spoken about what position of joints. I'm asking you, what splint will you apply?
So the pop-up splint with slight extension at the wrist and flexion.
Yeah, they've already mentioned that. Okay, team 2. I gave you a clue. It seems to be a very small child. How long? You talked about the position of the wrist and all that. How far is your splint going to extend? Up to the forearm? Up to the arm?
This is the second clue.
Above elbow. Yes. Above elbow for children.
Why above elbow?
As the children are restless, so they might be moving a lot over the elbow joints.
Always children, they will tend to take off the dressing if it is going to be below elbow. So for these children, it's ideal to put it in above elbow position. Above elbow position helps in two ways. When you put it in above elbow position, what position should the elbow be in?
Next.
What?
No, sorry. So extension, elbow.
You want to keep it in extension, then it's easier for the child to take it out. Team 1.
Flexion.
Huh?
Flexion. Elbow flexion.
Elbow flexion. I'll give you marks for that only if you say what position the forearm should be in.
In mid pronation.
Mid prone position. 1 mark to them, madam.
Okay.
Thank you.
Can I go, ma'am?
Yes, sir.
Yeah. I asked the team 1. You are answering very nicely. That's why I wanted to ask you a little difficult question. Well, in postborn contracture of fingers, when you release the contracture, then how you fix the contracture? How you fix it by what? You have released the flexion contracture of the finger. How you fix it? How you fix the release?
I will fix the contracture.
Yeah,
Sir, we will use the K-wire fixation method.
So on the table we find, the vascularity of the tip of the finger is not there. It is getting blue. Then what you do for that?
We will remove the K-wire if the vascularity is not good, and
you just remove it, or you wait for some time. Why there is a blanching, or why there is a blue coloration?
venous compromise, sir.
So why it happens?
Because of traction.
Yeah, due to traction, what happens in fact to the vessels?
Vasospasm of the vessel.
So you have to wait for some time. You don't just put the K-wire and get it out. It is not the way. You have to wait for the vascular spasm to be relieved also. It takes some time. Okay. Then the evening when you come to the ward, you find there is a problem also. Same thing. It is getting discolored, or you are not getting the blanching with the K-wire. What will do?
Now I will remove the K-wire.
You remove the K-wire. Okay. Then how do you fix it? Then how will keep the position intact?
I will splint it with POP. I will splint it with the POP, sir, with reducing the strain over the vessel.
Anyway, I will go to the what alternative method so that you can use it and you can help it afterwards, releasing it. You can put the threads into the nails, not to the pulp. And you have the release and you keep it in position. And if you have any problem on the vascularity, you can cut the thread. That is another method. Some people do it with the splint. Okay. So the second team I want, this team 2. Team 2, can I ask? What is Ganga gloves? Do you know there is a customized gloves for hand in Ganga? They have customized it. What is that Ganga gloves? I am not Ganga Hospital, I am talking of Coimbatore, not Ganga Ram Hospital. Any idea? In Ganga Hospital, there is a Ganga magnetic gloves being used for the patients for brachial plexus injuries for the hand. This is for your information, I just told you. Thank you very much. Madam,
Now
take
I
over.
invite the judges to ask a few questions. Vijay sir or Sanjeev Uppal sir.
Just a clarification on what is the position of immobilization of the metacarpophalangeal joint?
Team 1.
90 degrees. MCP flexion with 90 degree.
And what is the purpose of doing this?
So the purpose for this is that the collateral ligaments for MCP joint are
prone for contracture.
Prone for contracture in case of extended position, whereas in case of flexion there are less chances of MCP joint stiffness.
Can you explain why it is the chance of contraction is less when the MCP is in? Do you know what that particular effect is called?
Ligaments are.
Okay, we'll accept your. Does Team B want to answer that, or otherwise we'll
Yes.
accept your answer? Yeah.
Yes, it is called the CAM effect over
Okay.
the MCP joints.
So I'll give both of you 1 mark each.
Actually, in
that's-
this position, the ligaments are maximally stressed.
They are taught in MCP joint flexion.
You're right. It's a CAM effect, so I accept that. This. Carry on. I've finished.
Srivastava sir or Sanjeev Uppal sir, would you like to ask anything?
Take a minute. Dr. Sanjeev is talking to me, and we both have don't have any question to ask, so it is
Okay,
passed
sir.
on.
Madam, would you like to ask anything or shall we proceed to next spotter?
We'll proceed to the next one, madam.
Okay.
We'll proceed to the next.
I request Dr. Tanvir Ahmad and Dr. Abha madam to start the spotter for discussion. Dr. Tanvir Ahmad.
Yes. Okay. Which team?
It's team
Start
1.
with the B, madam.
Yeah.
First,
Team B.
Team B.
Yeah,
Team.
fourth spotter, team B.
Okay, the case history. We'll discuss the case history for a second. Will it require to tell the case history? No.
No.
Okay. Okay. What are the functional limitations used to be experienced by this type of neck contracture patient? The functional limitations used to be experienced.
Functional limitations, the patient is unable to look up or look at the ceiling, and because of the neck contracture, and also there is contracture of the lower lip because of it, because the
Difficulty in feeding,
and dental hygiene would be poor.
and there is extrinsic contracture over bilateral lower eyelids leading to ectropion.
Good. That means the limitation of the neck extension and problem with the mastications, swallowing problem, and dribbling of saliva, and with some exposure. Yeah, with the lower eyelids. Thank you. Good. How does this severe neck contracture actually affect during the intubation?
Due to neck contracture, the anatomy is distorted. So it is so there is difficulty in intubation. So we would first like to try for fiber optic intubation if it's possible. If it's not possible, then we would release the contracture by giving local anesthesia, followed by intubation, followed by further resurfacing.
Okay. If there is any further difficulties, what can be done? If you don't have any the fiber optic.
We can release a contraction by under sedation by giving local anesthesia, and
then we can proceed with the intubation. And if that is also not possible, then we can after release of the contracture, we can go for tracheostomy, submental intubation and tracheostomy.
Good. And what are the initial steps in planning surgical release? The initial steps in planning for the surgical release, or what are the things to be considered during planning for surgical options?
we would look for first look for donor sites also for a graft. Then I would like to measure my true defect for the assessment of graft. And I would first like to release the neck contracture.
And actually, the things related to the neck, what are the things to be considered?
Considerations in the release of neck, sir?
Yeah. Before planning for any reconstructive options.
Okay, we would plan for
Incisional release with fishtailing at the margins, and resurfacing by medium thickness split skin graft.
Okay, pass to the next thing. What are the things to be considered during planning for surgical options?
We have to look for the
seeing this neck.
We have to specifically look for the intrinsic and extrinsic contracture that is being produced here. Releasing the neck contracture intubation would have been a great problem. So if we release it locally, if it is not possible, we'll go with release of neck contracture followed by locoregional followed by resurfacing the raw area in three different sheets of graft need to be placed to achieve complete flexion and extension followed by medial and lateral rotation of the neck. Is the main concept.
Actually, before planning for any option, we should look for the scar quality, the presence of there is a scar or ulcer, and the skin availability, and the flap availability, so and the cervical span. These things to be considered before planning for any surgical option. Understand? Okay. So following release, what are the resurfacing options? Now you can tell.
We could go for skin grafting. Then we can go for dermal matrix followed by skin grafting. Then if the release is deeper and vital structures are exposed, then we would go for flap cover.
And which type of flap you are planning for here?
We can go for supraclavicular flap.
Can you please tell the advantages of the flap over the graft?
Advantages of flap resurfacing, sir.
Yeah, flap over the graft. Any two advantages?
In a graft, it would undergo secondary contraction, which is not the case in case of a flap cover. If the wound bed contains exposed vital structures, then skin graft cannot be applied over it. Flap would be a better option.
Okay, my last question. What long-term complication might arise even after successful surgical correction of this neck contracture? What complication can be arised following the release or reconstruction?
Recontracture can also take place.
Okay, thank you. I would like to over to my co-panelist, Dr. Abha. Abharani.
Yes. Ma'am, which team am I?
Team 1, madam. Team 1. 5 questions to team 1.
Team 1. Yes,
team 1, 5 questions because team 2 has had 5 questions. So team 1 needs to have 5.
So team 1, in the second picture, lateral view, what do you see? What's the nomenclature?
Lateral neck bands are also involved.
So there's a specific term when there is a neck contracture involving the neck, the bony landmarks involved.
What is the name given to this type of contracture?
Mentosternal contracture.
Yes. Okay. Next question is, you're planning for a flap, okay? Due to some reason, options for grafting is not there. How do you plan for it? What are the different steps? What would you consider?
We'll consider first locoregional flap cover followed by distant flap. In locoregional, the surrounding normal skin and the around normal non-involved skin will be taken into consideration. Pliability of the scar will be taken into consideration, and donor side morbidities need to be considered while doing the same.
Okay. So whenever we are planning for a flap as compared to a skin grafting, what's the difference? Primary difference in the donor site.
And the donor site, I will take the flap where the donor site will be primarily closed because I have no grafting, there is limited donor area.
Okay, the question is, how would you plan the size of the flap required?
By measuring the apparent.
What is apparent defect?
You have to calculate the apparent defect pre-operatively depending upon marking the landmarks
Is it apparent defect?
What do you mean by apparent in general
What is
terms?
apparent? What is other
apparent in
defect?
general terms?
True
Like
defect
in
and
basic
apparent,
English term, what do you mean by apparent?
which is
Apparent is what it is appearing to us. Okay. So it appears to us that the defect is this much, the size is X into Y, but the actual defect is another one. Okay. So the actual defect is the real defect. How do you calculate that? The real defect or the true defect, sorry, true defect. In any contracture release, how do you calculate the true defect?
patient in full flexion and patient in full extension. We have to calculate the what you say, distance between the bony landmark and
Yeah, okay. Can the other team answer?
Ma'am, I would first like to mark the line of maximal tension as my line of incisional release. I will take fixed bone. I will measure the fixed bony points to the line of my incisional release, and in a person of similar build and height, I would like to assess the mark the similar points, and I would like to assess the defect. That will give us the true defect.
Yes.
और कैसे बेटा?
Okay. In this patient, how would you stage the releases? So she has got a mentosternal contracture. It's involving the right axilla extending onto the right upper limb and then onto the left upper limb also. So how would you stage the releases and why?
Now it is team one only. Team one.
yes, yes. We'll stage according to the Makbul's classification, which include the degree of extension at neck and depending upon the scar, whether it is linear, whether it is broad, or it is moderate. So depending on that, we will it will affect our surgical plan of reconstruction. This is a severe mentosternal contracture with a broad scar.
Okay, my question is, which part would you address first, which you address second, and which would you address third? Like if you divide the components into three, like there's a mentosternal, the right upper side, right axilla extending onto the right forearm, and then left side also. If you stage it, I mean, if you divide it into three components, which one would you address first, which one second, and which one third?
I would like to address the neck contracture first, ma'am, followed by
Why is
proximal.
it so? Why is it that we address the neck first?
The intubation, anesthetic intubation is in
Yeah, so for
priority.
the surgeries, the intubation is easier. Next, which side would you do?
Next, the axilla, especially if post-operative splintage is comfortable for the patient, then I will love to go for axilla contracture release.
Does it have to do anything with the activities of daily living?
Yes, ma'am.
So which side would you do first? If
right
it is
side, dominant side.
Yes, we would address the dominant side so that the patient can take care of himself or herself. Okay. Next question is, the release has been done. The wounds have been grafted. What is the post-op, immediate post-op care or positioning that the patient would be on the bed?
There's neck in extension with shoulder. We'll do a bolster over the shoulder so that the neck will be in proper extension and complete immobilization. And we'll ask her to avoid movement at neck.
Okay, in these cases, is there any role of artificial skin substitute during reconstruction, during release of any contracture of the neck?
Yes, ma'am. We can use dermal substitutes, especially Integra can be used and stage reconstruction can be done. And because dermal substitute has shown good pliability and pinch test, so it will be good for the contouring also, and there will be good pinch and.
Yeah, I think thank you, ma'am. These are my questions.
Only 4 has been asked, madam. One
Okay,
more
ma'am.
question.
Yeah,
One more
one more.
question.
Yeah, so in post-op rehabilitation, what are the different things that you would be advising the patient to do? Or, saying use this, maintaining position, whatever.
So, and cervical collar will be prescribed to the patient in order to maintain the extension of the neck.
Anything else? Cervical collar. After that?
Physiotherapy exercises, neck extension exercise.
Yes, more. You have applied graft onto the wounds. So post grafting.
Avoid sun exposure, moisture application, and massaging over the.
And what would you do to prevent hypertrophic scarring?
Pressure garment, compression.
Yeah, compression garments.
Garments. Silicone.
What about maintaining the release that you have done at the axilla? Would you be giving splints? Yes or no?
Yes.
And for how long? What did you advise? How does the patient use the splints?
Initially, while discharging for 2 to 3 weeks, we will ask him to have the axilla release splint, aeroplane splint, 24 hours a day, and after that, we will ask her to nighttime splintage will be advised, and followed by that, when the splint is removed, we will follow up in physiotherapy we'll follow up in physiotherapy.
Yeah. Fine. Thank you, ma'am.
Can ask questions. Sir,
I
Chaudhary
think
sir. Sorry. Second.
it's
Yeah.
okay. Most of the questions are almost asked. Let me ask one question regarding counseling and taking written consent. What special mention should be done in the consent form regarding the prognosis of this patient? Such patient, severe contracture. Yeah. Which team? I don't know.
Team 1.
Yeah. Team 1. The consent is very important in such severe contracture. So, consent and counseling, what you should mention about the prognosis.
Prognosis. So, stage reconstructive procedures will be
Perfect.
required. Inadequate release, injury to the underlying neurovascular structures can be need to be explained with recontracture of the neck with post-operative requirement of post-operative splintage and physiotherapy to the patient, and loss of the graft area, the presence of raw areas post Kundili.
Perfect.
And,
I think perfect. Thank you.
Next
I don't
question.
have any more questions. Yeah.
One more question to Team B, because now it is unequal. Team A has got 6.
Tell me 3 advantages of dermal matrix in such cases.
Team B.
The
Team 2.
skin, the dermal matrix, the more dermis we provide, dermis leads to the inhibition of myofibroblast, which will in turn decrease the secondary contraction, and it provides better pliability seen in the cases in which dermal matrix are used. And
the integrity of the skin graft is better as compared to skin grafting alone.
Yeah. Cosmetic appearance is better. The split skin graft is converted into full thickness skin graft with the dermal matrix. Perfect answer. Thank you.
I invite Dr. Devi, sir, to ask some questions. Devi Mahapatra.
My question is to team 2. So, for this skin graft, when you are applying to the neck after release of contracture, what are the things you need to keep in mind that the outcome is optimum to get a good outcome?
Sir, I would like to apply 2 sheets of graft, first for the mental region, transversely, followed by second sheet over the neck. The juncture of the sheet should be transverse, so as to maintain contours of the neck.
Yes. Then
Yes.
anything else?
And the subhyoid depression should be visible. The submandibular bulge should be visible upon on reconstruction, and the inferior border of mandible should be adequate.
Good. Anything else regarding immobilization of the graft? How do you immobilize the graft? I think. Am I audible or?
Yes, sir. Yes, sir.
Yes, sir.
I think they got disconnected.
So 2 marks.
They gave the right answer. We will go with the second question to team 1. Team 1. In the immediate post-operative period, like our madam asked a little bit earlier, that position of the patient, what other things you need to keep in mind when a patient who has undergone contracture release of the neck with skin grafting? What are the other things you need to keep in the mind in the immediate post-operative periods, like within first 7 days?
Sir, in immediate post-op, the splintage is necessary, the position is necessary, the diet of the patient is necessary, and we need to catheterize this patient specifically, and low residual diet is to be given to her.
Yes.
And
what about this thing when you mobilize the patient?
We have to make sure that the splintage there and neck should be in extension while we get her up for. There should be less movement at the neck, sir.
Okay, and when do you do the first dressing of the patient?
First check around 7th day, sir.
Okay, we'll accept it. 5th day you can open it, but it's okay. 5th to 7th day. Okay, madam, from my end.
So
Can I
7
start?
questions equal. So equally, 2 teams have got 7 questions, sir.
Thank you. Can I start, ma'am?
Yes, sir.
Thank you so much. The team 1 team, can you just tell me in very few seconds, not by going a long diagnosis, what is the full diagnosis of this patient? Team 1?
Yes, sir.
Yeah, Mrulan, what is the full diagnosis of this patient?
Yes, sir.
In very short, I don't want a long one.
Yes, sir. She's a X-age female with.
No. I'm asking diagnosis. Very short diagnosis. I'm not going detail.
Severe mentosternal contracture neck with intrinsic and extrinsic.
No, that is not the diagnosis. There are structures involved in this. What are the mostly the joints are involved, no? So what are the joints that are involved?
Bilateral shoulder, bilateral elbow, cervical, and
We should have post-born contracture of the neck with bilateral axilla, and bilateral elbow also. Hyperpigmentation patch of the left side chest with a unstable ulcer over the scar. Have you seen that?
Yes, sir.
And ectropion, that is a effect of that, what you have told. Ectropion of the lower lip.
Lower eyelid.
So all these things are the final diagnosis. Anyway.
Along with breast contracture.
Yeah. There is another, rightly sir told, there is a breast also, left side breast is distorted. So nipple area complex is not in the proper line. And what is your management? What is planning in reverse? Plastic and reconstructive surgery, PRS. Planning in reverse. What do you mean by that? Sorry? Please be quick. What is planning in reverse? You ought to know as a plastic surgeon. I told plastic and reconstructive surgery planning in reverse.
The question should go to team 2 now.
Okay. Thank you so much, sir. So question go to the team 2. What is planning in reverse?
The planning in reverse is from defect to donor side. First, we assess the defect, then we go to the donor side to plan according to the defect. We create
Then
a
what is
template. We create a template.
What is mean by the apparent and what is a true defect?
The apparent defect is the one which appears to us, and the true defect is the defect we measure from the fixed bony points in a.
Stop. How do you make a true defect in this patient?
We assess the true defect in a patient of in a person of similar build and height, and we assess.
Stop. Then how do you make a true defect? What are the markers?
We mark our incisional or excisional release and measure it with the fixed bony points. And similar marking we do on the person with similar height. And we measure the same distance from the fixed bony points to get our true defect.
Done, I think. The second question to the first team.
Sir, can we give the full marks to them?
Second team will get it, no doubt about it.
Okay.
Yeah. So, in this case, what is your planning of management?
Team A1.
Team 1.
Sir,
Just shortly, I don't want detail about it. How do
planning,
you use this case? What is your planning?
Multiple contractors involved. We will prioritize first. The next contractor will be. Since
What type of you want to do? What type of release you want to do?
Sir, incisional release.
Not excisional release? You have a ulcer, no? Post-burn scar ulcer is there. Have you seen that?
Yes, sir.
Then you want to take away that ulcer, or it will be there only?
No, we will send it for HPR, sir.
Okay, so there will be a release. Then after release, which part will do first?
Which?
Neck, elbow, or axilla? Neck. Okay. For information that in last, I think in 3 decades, in my center in SCB Cuttack, we have never done a tracheostomy. So don't go for a tracheostomy. Most of the cases, I will agree with the senior surgeons. You can go ahead with, even though you don't have a fiber optic nasal intubation, but still you can manage with a local, or my anesthesia is good enough. He gives ketamine infusion, and on that you can release it. So it depends on the anesthesiologist what choice and how confident he is in this case. I think it can be done. So there is no need of a tracheostomy. That I just mentioned because somebody has told about tracheostomy. Well, then after release of neck,
I will like to cover it with graft, sir.
What type of graft?
Medium thickness graft, STG, medium thickness.
From where?
From thigh.
From where?
Medial aspect of thigh.
Okay.
If the donor sites are available.
So what about the axilla?
What about the we can release it in simultaneous exposure.
I will go to the second team. Can you answer the rest? Second team, can you answer the rest in the management? Second team?
Yes, sir.
Yeah.
Will you do axilla simultaneously?
Yeah, that is
So we don't want to do axilla simultaneously because the post-operative position of splinting is.
Okay, you are right. You are right. Then what will do after the?
In stage 1, I would like to go for neck release followed by axilla release in stage 2.
Yes.
And in stage 1, I can also include the correction of lower lid ectropion.
Yes. Then what about the breast? What about the hypopigmented patch? All that you take care or not?
So later, after I release the
Till
neck and
stage
axilla,
1,
later on
2,
I can move
3,
it.
like that.
Oh, okay.
So in the next stage, we can go with elbow and dermabrasion of the hypopigmented scar over the chest, followed by melanocyte transfer.
Okay, those are, it depends on, I think, requirement and counseling of the patient and so on. So it is not just straight answer. It will take its own way of counseling the patient and getting the right way of management. Then you know what is a mutter flap? If you ask, I am asking you, the team 1, what is a mutter flap? Mutter's flap, team 1. This is the last question to both. If team 1 answers, I will ask something to both team 2. Team 1, what is mutter's flap? In the neck. Team 2.
The flap in supraclavicular region extended till deltoid.
Then how do you have to nomenclature it, na? You have to
Two parallel
nomenclature.
incision lines are given over
No, this is
supraclavicular.
cervico-humeral flap. This is cervico-humeral flap.
Yes, cervical.
So you can make it a also random pattern at the distal and you can delay it, all that. It's not being used nowadays, but for all practical purposes, you should know for your exams.
Sir,
I hope I am done. I am done. Dr.
Sir,
Karthikeyan.
do we give a mark for the team B?
I think, no. I think
okay.
nobody gets the mark.
Okay,
Nobody
sir.
gets.
Okay.
Now I request the judges to ask few questions.
May I?
Yes, sir.
Yeah, yes, sir.
This is a severe contracture. Team 1, I should ask. Huh?
Yes, sir. Yes, team 1.
So team 1, what could have been done in initial stages to prevent or minimize this contracture?
Sir, to prevent this contracture in early stages, the patient should have been surgically intervened like tangential excision so as to decrease her contracture in future, or post-operatively, while discharging, or when patient was admitted under proper neck splintage and axilla splintage should have been given, followed by physiotherapy.
Okay. If you were not having that tangential excision facility, then our patient was having extensive burn, even then, could you do something?
Sir, adequate resuscitation with splintage.
Yes, proper splintage. Resuscitation has no role in that. Okay. The second question I want to ask.
Team B, sir. Team B. Team B.
Team B. That you told that you will be giving incisional excision, incisional release. Okay. And you will be covering it either by the graft or by flap.
Yes.
Where would you like to have the this scar line after release? In which areas you would like to have the scar lines?
At junction
You
of
have to consider
cervicomental junction, sir.
Cervicomental junction. So your incision should be?
I would like to give incision over the point of maximal tension on the contracture band.
Will you consider anything else while giving the incision?
So we want to
I will
extend
give
the incision.
extend the incision till normal skin, and I'll give fishtailing at the ends of the incision
And in the center?
to break the linear contracture line.
So you will be giving some vertical incisions.
And yes, the darting incisions can also be given if we feel contracture still
that
persists.
in which area would you like to prevent something having a scar line? Some structure should not have the scar line.
Neck.
Will you be able to completely have the cervicomental angle area till that area skin, this is skin, after giving the incision? You are getting my point or not?
So can you repeat,
scar
sir?
Scar line is placed where? Would you like to have it just below the lip? I am giving you the hint, or over the chin, or somewhere else.
In mental,
cervicomental region.
in cervicomental
That
junction.
incision will not go in cervicomental region. Team 1. You don't have that much skin. Huh?
Scar should be below the chin, sir.
Yes, it should be below the chin. You will need 2 grafts or the flap when you are interpositioning. That should come into cervicomental region.
Yes.
You put 2 grafts so that the joint of graft comes in cervicomental region. Okay? But in any case, it will release the lip ectropion also, and it should always be below the chin, not over the chin line. Got it?
Yes, sir.
And the second thing, once you give the incision line proper and this contracture is released, the neck contracture, you will see lots of problems you are having here will be little bit lessened. Like the ectropion of eyes, the elbow contracture, others, because the things have been pulled up. So you will first release the neck. Only after reassessment, after some time, that proper time given to settle the scar, you will be considering correcting the other contractures. And one more thing only, if time permits, the classification of neck contracture. Do you know? Second
Yes, sir.
team.
Yes, sir. Osher classification. It is mild, moderate, severe, and extensive. In mild, the
Only
patient is
give the degree of neck.
this
1, 2, 3.
in this patient. In this patient, it is extensive contracture, that is mentosternal adhesion is seen.
So
Along with
it comes
the
into
distortion of anatomy of lower lip.
It comes into which?
Extensive grade 4 Osher classification.
It is only 1, 2, 3. Mild, moderate, severe.
Mild, moderate, severe, and extensive, sir.
Osher gives only that 3. Maqbool gives that.
Okay. Okay, sir.
And the angle is 85 to 110, 95 to 110, 85 to 95, and the severe. Okay, thank you.
So one question to team 1 now, because it is 11 for team B and 10 for this thing. So what is the dreaded complication of when you release a neck contracture? What is the dreaded complication for when you do a neck contracture release? Team A.
Blood loss will be the blood loss, extensive blood loss.
No, something else. No. All that can happen. You can lose the patient.
Cervical.
When you do a neck release, you can lose the patient due to something. I want what happens, why you lose the patient.
Cord compression. Leading to
No. Can I pass it on to the next team?
Ma'am, hematoma development in the
No.
Injury to vascular structures in neck.
No. So I'll give the answer because it is getting late. Due to sudden, when you do a sudden release, there can be an atlanto-occipital dislocation directly compressing the respiratory center, and we can lose the patients. It's a dreaded complication, especially when you do a neck release. That too, in severe cases, and you suddenly do a release, and even when the anesthetist is trying to intubate after you do the release and give, and they do it, perioperatively, you may not actually find out. Post-operatively, the patient doesn't come out, and then we know that the patient has had a atlanto-occipital dislocation directly compressing your respiratory center in the medulla. So that is a dreaded complication. So I'm not going to give marks to both the teams.
Thank you, ma'am. Now, any patrons? Dr. Rajiv sir, would you like to ask any questions? Rajiv Ahuja sir. Dr. Vinita ma'am.
Yeah. Hi, Dr. Lakshmi.
Good evening, ma'am.
Good evening, and good evening to everyone. So I don't really want to ask any questions. This has been an amazing session I've been hearing. And I'm sorry I wasn't there right in the beginning because of some family matters that I have to attend to. But yeah, no questions to ask anyone. Most of the questions have already been asked. Thank you.
So, Benita, are you ready for your conference?
Oh, yes, absolutely. And I'm looking forward to having the finals of Plastiquest there. And I'm sure the residents are also going to look forward to the prize that we will give them.
Yeah, thank you so much for
Thank you,
sponsoring.
Yeah, no problem. My pleasure.
Give your message, ma'am. Actually, we missed it. Actually, we had little glitches also in the starting.
Okay.
So we started the program main session. So you give your message. We are conducting along with the Apbc 25 for the first time.
Yes. So what can I say? I think I want to wish all the postgraduate students all the very best, all those who are taking part in Plastiquest. And we are looking forward to having not just Plastiquest, but also a burn quiz at Apbc. So I hope not just the burn quiz is not just for the PG students, but it is for all the participants, all delegates of faculty, whoever wants to attend the burn quiz can take part in it. We will send out the applications later, much later. Otherwise, we are presently in the process of putting the scientific program together, and we are going to have many symposia. There are going to be very senior people. We have very senior people from abroad as well as from India who will be speaking in the conference. Personally, as a team, we are all very excited that we have had an opportunity to host the Asia Pacific Conference in India. So I think with the help of everyone out here who is there, we have so many senior people out here. And I think with everybody's help and blessings, it should go well. And everybody should have a good
I
time,
think
not
the
just
students should not miss this
academically, but
conference.
also, it's Goa, and we'll let everyone have a great time even in the evenings.
I think the young people should be motivated to go and attend this. They may not get in their lifetime always, because it happened in 2009. After that, it has happened this time, I think.
Right. It will take some time before it comes back again. That's true, Dr. Chaudhary. Thank you for these encouraging words.
Thank you, Vinda.
Definitely, ma'am. It will be a grand success, and many people are waiting to participate actively and dynamically.
Yeah, I also want to tell everyone that we are doing a lot of workshops on 21st, and workshop registration is free for those who are registered as for the registered candidates of Apbc. Because we are putting in a lot of efforts to do these workshops, we are opening up the workshops also for the ones who are not registered. In case they cannot come for Apbc, we are opening up the registrations within a certain amount for others also. In India, I don't think anybody is going to come from abroad only for the workshops, but at least for people from India, some PG students, and if there are any other seniors who would like to attend, they can attend with consultants and PG students.
Thank you, madam. Thank you very much.
Thank you.
I'll hand over this to Dr. Umar to take the feedbacks who would like to give about Plastiquest challenge. Meanwhile, I request the judges to tabulate and give the marks and tell which team is proceeding to pre-final. And I request Rohit, just show the follow-up photos of spotters, 3 spotters. We have the follow-up, post-up, how they are treated. This foot was treated by Dr. Neela Bhattacharya. It was treated conservatively, used hydrophilic silver foam dressings and Emsol hydrochloride gel. After 9 days, but you can observe the pressure points are deep and few areas healed spontaneously with the conservative treatment, and deep burns are there on the pressure points after 1 month also, but the patient went on Lama and getting treatment at home only. So their wounds are not grafted and further treatment is not given. So this is spotter 2. If Neela is there, already she discussed. So is spotter 3. T excision and grafting was done by Dr. Bemde sir. Would you like to tell anything about it, Dr. Bemde?
The tangential excision was done using Goulian knife, and immediate mesh graft was put, but unstretched mesh graft you can see with vertical slits, especially. And this is the post-op after 3 weeks.
Is it
Having
combination of meek and as well as mesh
meek was
graft, I think?
meek is
Yes.
on the distal forearm.
Forearm, yeah.
Yeah.
Yeah, nice.
Generally on dorsum of hand and fingers we avoid meek.
Yeah.
We
Do
use
you,
mesh graft but without stretching.
okay. So it is a 1:1.5 mesh
1:1.
you have
1:1 you can say.
Yeah.
1:1.
So would you like to prefer the mesh graft over the sheet grafts for the dorsum of the hand also?
Yeah, sheet graft is also welcome with minimal holes. Yes,
Okay.
definitely.
Yeah.
If there is a oozing, I
Yeah.
go for more
Meshing.
meshing. If there
Yeah.
is no oozing, good hemostasis, then sheet graft with minimal slit holes manually. And if there is a
Yeah.
meshing, I take care that the meshing should be in vertical direction, means parallel to the finger axis, long axis of finger.
Okay.
Yeah. So that the contracture, secondary contracture chances are less. And it should be put in the maximum fist position, flexion position, the graft.
Yes, sir.
Maximum
The
graft should
maximum
be.
surface will be
Yeah.
available for
Yeah.
the surface of the
Yeah.
skin grafting. Okay.
Yes.
Yes.
Thank you.
It's very good results. This is the 4th spotter, which was given to you. This is done by Dr. Pradeep Gupta from SMS Hospital, Jaipur. So you can see the front view and as well as the lateral view. The mentosternal angle is maintained and contours up to some extent are good. And maximum areas are resurfaced with this grafting only. And the ectropion and all these are secondary contractures to, they are not released. They are corrected with the neck and lip release itself. Okay. So you can observe the correction of the ectropion of the lower lid as well as a little of axilla also, which axilla they should be corrected in the second stage. Okay, then the spotter next is Dr. Umar Farooq Baba will take over and take few feedbacks of faculty and PGs.
Hello, good evening to all. I will not take much time because we have already overshoot the time by about an hour.
Yes.
So we'll start with the patterns. Any feedback? All the feedbacks will help us to take it further ahead the program. So feedback from the patrons, will start from the patrons.
Dr. B. Venkatratnam, sir. Or
That is
Dr.
there
Bhattacharya
only.
is not available.
Yeah.
Uh,
Venkata sir
Good
is
evening
there.
to all. Since it is a feedback, there are no questions. First thing is, I congratulate all the organizers and participants, both from faculty side as well as from student side. It's an excellent exchange of information across the country, and it's a lot of subject is there. Of course, burn is a very big subject. We cannot cover everything, but lots of points are covered. Congratulations again to all the team. Next is my special congratulations are to Dr. Angelina. My goodness, she carefully she was following the timing as well as allotting to the teams precisely. It requires a lot of attention to the subject as well as to the process. Thanks and congratulations to Dr. Angelina. Next is Dr. Mahapatra, Dev Mahapatra. Well done. My only point or reminder to him, probably is a question to him also, is I think your institute is doing LAD. I think there is a role for LAD, limited access dressing, or NWPT, NPWT. So it is just a reminder. So in case such an occasion there, please try to introduce that. Next is to seniors, all the seniors, examiners, to professors, everybody. It's a request to participate in as many as possible for your according to your convenience, so that see the amount of questions, amount of knowledge. Some questions, believe me, some questions I cannot even imagine. Such a vast experience. So please participate and share your knowledge. And of course, we are also learning. Final point is, it is probably to everybody, final point is, regarding blister management. Just one point I want to tell is, especially for the PGs, please go to the literature and find out whether there is any blister which is infected and that infection has spread to the surroundings. Any study, any one point. So my point is to bring out, it is the surroundings which get infected and the blister which gets infected later. So there is a lot of literature available. More than 700 articles are available. So because why I am telling is, some of my patients, they come with the blisters, they refuse for treatment, and then because of the pain or whatever it is, after 1 week or 10 days or so, blister ruptures and they come back happily. So then I went to the literature. Then this is the finding I found. Then I conducted a study over 3 years. So that I published the conservative management for the burn blisters. So it is published in Journal of Society for Wound Care and Research in 2012, number 5(1). That is the thing, pages 23 to 28. So being inquisitive minds, please try to go critically, think critically, find out all the answers, try to read between the lines, and then try to develop your own thoughts and tell others your experiences. This is all. Thanks for giving me the opportunity. Thank you.